Hi, I'm Dr. Kevin Dawravoo. I'm a medical oncologist over at the Northwestern Cancer Center in Warrenville. I'm here to discuss colon cancer today, and wanted to also see if anybody had questions after the talk. So, just starting real general, colon cancer is a very common cancer that affects thousands of patients every year. It's the third most common cancer, actually. And when you add up all the cancer-related deaths, men and women, it's the second most common cause of cancer death in America. An interesting fact is that with colon cancer, if people just went for their normal colonoscopies and colon cancer screenings, 50% of the cases would never get to the medical oncologist. They would never require surgery. And the reason for that is the gastroenterologist would be able to detect ththese polyps, these precancerous polyps or very early stage cancers during the colonoscopy and treat them at the time of the procedure. So half the cases that I see I would never need to see if patients just underwent normal colon cancer screening. So that brings me to what are the recommendations currently for colon cancer. Right now, the American Cancer Society, I believe it's been in the last year or two, has recommended that screening begin at 45 years of age. For many, many years, it's been 50, but because we're seeing cases of colon and rectal cancer happen at earlier ages, that age cutoff has dropped to 45. So yes, the incidence has been rising, particularly in younger individuals. The fastest rise of colorectal cancer has been in age groups 20 to 39. It's really difficult to determine why this is occurring in such young patients. There are many theories out there. Some of the data shows that, could this be due to decreased fiber intake in our diet? Or are we just being exposed to more chemicals, whether environmental or through our food? It's hard to tell. There have also been some papers discussing, aspirin use and how that has decreased over the last few decades significantly. Aspirin has been shown in a number of studies to be protective for patients with colon cancer and after they've been treated with colon cancer. So maybe because of our decreased use, we're seeing cases earlier on now. Again, going over the presentation for patients with colon cancer, some patients have no signs or symptoms at all. And, these are obviously the most worrisome because there is really nothing that these individuals could have done to detect it sooner, other than going through normal age-specific screening. Some of the more common symptoms include diarrhea, abdominal pain, bloating, nausea, blood in the stool. And the blood can be bright red blood. It could be really dark, black, tarry stools. These are all signs that you need to see your doctor immediately and get evaluated. Fatigue, new onset anemia, and weight loss for no known reason are also other causes for seeing your physician for an evaluation. So looking at risk factors for colon cancer, age is a big one. 90% of colorectal cancers occur in patients over the age of 50. But like I said, we're seeing a higher incidence in younger patients now. And that's predominantly, we're seeing the younger patients in the rectal cancer, but of all types. Diet is especially important. So red meats, which includes beef and pork, are known carcinogens for colorectal cancer. So the initial studies and the follow-up studies that came out of one institution, Dana-Farber, which is the Harvard Cancer Center, by Charlie Fuchs, showed us that he took a large group of patients, and patients that started eating more than one time per month of red meat, he started to see a linear relationship increase in terms of their risk for colorectal cancer. So obviously, most of us probably eat red meat more than one time per month, but it's just something to keep in mind to try to limit our consumption of red meats, and especially how we cook them. So charring these foods can also increase carcinogen risk for us, and so decrease your red meat consumption and also be careful about how you cook them are important. Obesity is another risk factor for colon cancer, along with many other cancers. Obesity creates an inflammatory state in the body, and we believe that is a risk factor for developing many different types of cancers. And that also could be another reason why we're seeing it in younger and younger patients. Inflammatory bowel disease. such as or any type of inflammatory disease, can increase the risk of colon cancer. Smoking, sedentary lifestyle, alcohol, diabetes, and prior history of abdominal radiation are all risk factors for colon cancer. Now, beyond these risk factors, there's also a genetic component to most cancers. 20% of colon cancers are believed to have some type of genetic link, and that's why for any patient that gets diagnosed with colon cancer, we run specific tests looking to see, is this cancer genetically related, or was this more of a sporadic development of the disease? So what can you do to decrease your risk of colon cancer? Well, physical activity is definitely a protective effect. By doing that, hopefully, we'll be able to decrease obesity rates and you maintain a healthier lifestyle. Increase your diet intake of fruits and vegetables can also help. There have been numerous studies looking at vitamin D consumption, and what vitamin D has shown is that it has a protective effect on colon cancer, not only on preventing it, but also on decreasing the risk of recurrence in patients who have had colon cancer. So any patient that I see in clinic, I recommend that they take vitamin D during and after treatment because of its protective effects. And so what I've done in my practice is, for any patient that has come through and I continue to follow for many years, I will check their vitamin D levels to make sure they're adequate, and we continue to follow that lifelong. So in terms of the advances in colon cancer, I think it's important to look at what's happened over the last few years. In the past, we used to group all patients with colon cancer as basically one group. Now we've learned that there are really 4 different types of colon cancers, and this has been developed as a result of all the different types of molecular testing we do. So embryologically, meaning where these organs have developed from the time we were a fetus, these different sections of the colon actually develop from different parts of our body. And so we've figured out that there are 4 main types of colon cancer molecularly. And in turn, that has led us to demonstrate that different types of treatment can impact patients on different levels depending on which side of the colon cancer they have. So for right-sided tumors versus left-sided, certain drugs work better. And so that has had a direct impact on how we treat patients, primarily in the metastatic setting, but in the future that may change how we treat patients even in the local setting. And this has been a significant shift in the way we think of colon cancer. Now, looking at the different types of treatments for colon cancers, the most common type for localized treatment is surgery. And whether or not you get chemotherapy or any type of treatment after the surgery will depend on the stage of your cancer. The mainstays for treatment in metastatic disease include chemotherapy, which is the use of chemicals to try to kill the cancer cells. We've also developed what we call targeted therapy, which really came about in full force for colon cancer in about 2004. So targeted therapy is basically the development of antibodies that specifically target proteins on the surface of colon cancer cells. And these antibodies are infused into the bloodstream, just like delivery of chemotherapy. We do it through the IV. And the drug then basically circulates and targets, it's an antibody, so it targets a specific protein on the surface of cancer cells, and we're able to more specifically kill the cancer cells than we would be able to with chemotherapy. The most common, one of the first antibodies developed was a drug called Avastin, which is used in many cancers. That drug inhibits blood vessel formation, so its role is really to starve the cancer cell of nutrients and also decrease its ability to spread to other organs. We have developed other antibodies over the years looking at different proteins on cancer cells. And over the last few years, we've developed a whole new category of treatment called immunotherapy. So immunotherapy is, I'm sure we've all seen the commercials. It's used in many different cancer types, and we use it in colon cancer also. Immunotherapy activates the immune system to basically have your white blood cells, which is your main cell in your immune system, to recognize cancer cells as foreign. And they do that by attaching themselves to the cancer cell and decreasing its ability to camouflage itself from the body. And so because you are now activating your own body cells to attack the cancer cells, you don't see as many toxicity for the majority of patients with immunotherapy when we compare to chemotherapy, which is a chemical that really, can kill normal cells along with the cancer cells. And so because this is more specific and targeted, most patients have less side effects overall and can do very well on these drugs. And these drugs have revolutionized cancer for a number of patients. They're not a slam dunk or a home run by any means. Many patients are not candidates for immunotherapy. We only want to use it in the right patient. And so what we do is we send off for specific types of tests to tell us, yes, this patient will respond versus not respond. And based on the results of those tests, if you have certain protein levels or expression levels of other types of proteins in the body, that will tell us, that you're going to be a good candidate for immunotherapy. So those are the main types of treatments that we have for colon cancer right now. One distinction between colon cancer and rectal cancer is that the rectum is really the last part of the colon before the anus. Okay, and so because of that, it is fixed in the body, and typically the way we will treat that in a patient who has a slightly more advanced rectal cancer is we'll utilize radiation therapy in those settings. So that's a little bit different than the colon in that we use surgery and chemo. Rectal cancer, we will use all three modalities to treat many of the patients with more advanced disease. So at this point in time, I wanted to see if I can answer any questions.
So Tay is asking what your thoughts are on increasing dietary fiber, and if that's a good recommendation, what types of dietary fiber?
Yeah, that's a good question. I think increasing fiber is advised and recommended. In terms of what types, I think just any type of fiber like benefiber would be fine, and using that once a day, you don't want to overdo it either and then develop diarrhea. So just trying to see what the right dose is for you and taking it regularly, whether that means once a day or every other day, I think is very reasonable.
Are colonoscopy screenings still happening with COVID?
They are. So that's a great question. With COVID, many things have been delayed, and some things that could have been delayed should be delayed, but others shouldn't be. So if you're having symptoms, new onset abdominal pain, or any of the things that we talked about, blood in the stool, changes in stool, such as new diarrhea, new constipation, both, these are symptoms that I wouldn't really delay, and I think it's time to go talk to the gastroenterologist or at least your primary care doctor. The gastroenterologists have opened up their clinics, and they are doing procedures at this time.
Is there a special diet after colon cancer treatment that should be followed?
No, not anything special that I wouldn't recommend for even just the average person who wants to lower their risk. So again, I advise all patients, and I go over this again and again, even after that I've treated them with chemotherapy at each follow-up visit. Try to decrease your consumption of red meat. That's pork and beef. Try to limit your consumption of charred foods. Fruits, vegetables, maintaining a healthy lifestyle, exercising, and then vitamin D.
Does my diagnosis of colon cancer mean my relatives have a higher risk?
It can. Right now, the recommendation is if you have a first-degree relative who has colon cancer, the guidelines tell us that you should be getting colonoscopy 10 years before that individual was diagnosed. So say your father was diagnosed with a colon cancer at the age of 40. That means you should be getting a screening colonoscopy at the age of 30. And again, looking at the regular guidelines, 45 is the new recommended age for patients according to the American Cancer Society. Not all societies have transferred over to that lower age, but in my opinion, given the amount of younger patients that we're seeing, I would definitely recommend considering the lower age, and especially if you have family history, I would do it.
Barb is asking, why vitamin D?
So it's a good question, and in terms of the actual mechanism, it's hard to say. I don't know the science behind it, but looking at numerous trials, not only from Dana-Farber but from multiple other institutions, we're seeing a direct correlation in lowering the risk of colon cancer, not only in those patients that have had colon cancer, but also in almost like a preventative measure. So vitamin D isn't something you should take lightly. I don't think it's something that I would tell everybody to do unless they're willing to be monitored on them. So every patient that I see, I make sure I check their vitamin D levels at every visit so that we make sure they're not getting too high.
Okay, and last question, unless another question comes in through Facebook Live. How do I get my treatment summary and survivorship care plan to keep in my personal records?
So we have a survivorship clinic set up at our institution where every patient that completes training, curative treatment for their cancers will get a survivorship visit. And at that visit, we will talk to you about general aspects of cancer care moving forward. We go over the red meat, the vitamin D, and other dietary modifications that we tell our patients. So that visit should be set up automatically at the completion of your treatment. And if you need that to be summarized, what I would recommend is just calling the clinic, and we'd be happy to give you a summary of all the recommendations.
And Dr. Dawravoo, I wanted to circle back. There was a question that came in prior to our Facebook Live regarding stress and the COVID pandemic. This participant wrote in saying, could stress cause bowel discomfort and cramping, especially since they've already had prior colon surgeries? And is this something she should be worried about, or is it stress related?
Yeah, so stress can definitely change your bowel habits. Stress can cause diarrhea, it can cause cramping, it can cause nausea, it can cause fatigue, it can cause many symptoms. But I would say, if these symptoms continue and I would say if these symptoms continue, it's important to get it evaluated. You don't want to ever assume anything. So, one thing I tell my patients is, even if you have a history of hemorrhoids or anything like that, you don't ever want to assume that the blood in your stool is due to that. We never want to make assumptions in medicine. So I tell them whether it's something like that or even in terms of your stress-related symptoms, you don't want to assume that. If those symptoms continue, I would make sure you get evaluated.
Jan is asking, what is a healthy vitamin D level and a correlated maybe daily dose you should be taking?
So it's different for everybody, but according to our lab at Northwestern, normal levels range somewhere between 31 and 80. And so I try to keep patients at least in the middle to higher range. We don't want them to be too high because you can develop vitamin D toxicity. So that's why I said earlier, don't start taking it and not get monitored. It's important to monitor these levels because you can get vitamin D toxicity. But my goal is to get you somewhere between 50 to 60 if I can. And the levels are highly variable. Some patients need 1,000 a day, and then I have others that are taking 8,000 a day, 10,000 a day, and they're still low. So it really depends on the individual and how well their body absorbs it. So I would recommend talking to your primary and seeing what dose they recommend you starting at, probably getting a baseline vitamin D level, and that'll help guide your initial dose.
No other questions?
Great. Thank you.